Hello friends, today we'll be discussing the neuroradiology part of radiology, and it being a little lengthier topic, we'll discuss it in two sittings. So in the current session today, we'll discuss the head trauma and skull fractures, and the subsequent session that will take later, I'll discuss neurocutaneous syndromes, stroke, CNS infections, leukodystrophies, spine tumors, and some miscellaneous topics. So coming on to head trauma, it is a very important part because at least one question is definitely asked in PG entrance exam, either from EDH, SDH, SH, or some brain tumor. So some thumb rules before we go on to head trauma. What is the investigation of choice, or what is the initial investigation when it comes to head trauma? The answer is a non-contrast CT scan. All right. Remember, there is no role of X-ray in head trauma. And MRI, what is the role of MRI? It is only done when you're suspecting a diffuse axonal injury. And amongst MRI, the sequence of choice is a susceptibility weighted imaging. Now, sometimes you won't get FWI in your options. You'll get a gradient recall echo or a T2 star weighted imaging. All of these are a correct answer. Right. So when do you do a CT angiography when in head trauma? Only if you're suspecting injury to the internal carotid artery. Now, when do you suspect? As we all know that ICA runs along the foramen transverse cerium of the cervical spine. So when there is a fracture of foramen transverse cerium on NCCT, or there is a skull base fracture involving the carotid canal. So for example, there is a fracture of the temporal bone or a foramen lacerum, the carotid canal is more likely to be injured in such scenario, and hence you'll do a CT angiography. Now, when to do a head CT in trauma setting? So various societies have given different criteria, namely Canadian C-spine rule, New Orleans criteria, Nexus, and Denver criteria. Amongst these, they tell that in any major head injury, that is in patients having GCS less than 13, you should do a head CT to rule out intracranial hemorrhage. And in minor head injuries, that is patients with GCS 13 to 15, if they have any of the following, you should do a head CT. So if they have suspected open or a depressed skull fracture, for example, there is a big laceration on the scalp, you suspect that there is a intracranial hemorrhage also associated. So you'll do a head CT. Any sign of basal skull fracture, so for example, there are raccoon eyes or there is bleeding from the ear, you suspect that there is a skull base fracture, and hence a head CT is warranted in such cases. Two or more episodes of vomiting, there might be increased intracranial pressure secondary to hemorrhage, so you do a head CT. 65 years or older, even trivial trauma in such patients can result in a head trauma, so you'll do a head CT. There is amnesia before the impact of 30 minutes or more. You want to rule out intracranial hemorrhage in such situations, so you'll do a head CT. In any dangerous mechanism, for example, a high impact accident, you want to rule out an IC bleed, so a head CT is warranted as well. Now, the intracranial bleeds are broadly divided into two main categories: an extraaxial bleed, that is outside the brain parenchyma, and an intraaxial bleed, that is those bleeds occurring inside the brain parenchyma. So, in intraaxial bleeds are two main important bleeds, namely cerebral contusions and diffuse axonal injuries. Extraaxial bleeds are namely four: FDH, EDH, SAH, and intraventricular hemorrhage, IVH. So before we go into the individual bleeds, I want you guys to know a very important concept of an extraaxial versus an intraaxial lesion. And this will also help you to understand brain tumors better, and also your general understanding of brain MRIs, right? So for example, on the image on the left, we have an image of brain in which the brain parenchyma here is surrounded by these vessels, and overlying these vessels is the meninges, right? So think logically, if there is a tumor outside the brain parenchyma, so extraaxial lesion, we typically tell the lesion arising from dura, bone, or the scalp, right? Sorry, the meninges, bone, or the scalp. So if there is a lesion arising from the meninges, so what will it do? It will push the vessels inside, right? You can see here that the vessels are in between the lesion and the brain, right? The CSF will be between the lesion and the brain. So for example, if there is a meningioma arising from the dura mater, the CSF that is present inside the arachnoid matter will be present between the lesion and the brain. The vessels will also be present between the lesion and the brain. So these are the definite signs that the lesion is an extra-axial location. So a CSF cleft, vessels interposed, cortex between the lesion and the brain, and dura mater between lesion and the brain. These are definite signs that the lesion is extra-axial. Some soft pointers of an extra-axial lesion is a broad base mass along the dura. So for example, there is a meningioma here. It is broad based towards the dura. So there are more chances of it being an extra-axial lesion. There is an overlying bony change. So there is hyperostosis of bone, or there is enhancement of the adjacent meninges. This is also known as the dural tail sign. These are soft pointers that the mass is arising from meninges or the skull, right? And the displacement of brain from the skull is also a soft pointer of it being an extra-axial mass. Now coming on to the main discussion today, that is head trauma bleeds. So the extra-axial bleeds are namely divided into EDH, FTH, SAH and IVH. And amongst these, EDH and FTH are very important because these are the most frequently asked questions in the PG from head trauma. So before discussing the imaging findings, the brief clinical history that is sometimes given in the question is so for example, EDH will have a high energy trauma, whereas FTH can also occur even if there is a trivial trauma. That being said, that FTH can also occur if there is a high energy trauma, but if for EDH to occur, high energy trauma is usually required, right? EDH is almost always associated with the bone fracture. The most common location of EDH is temporal bone, and hence the temporal bone fractures are most commonly associated with EDH. Important point to remember is that EDH are arterial bleeds, and the most commonly involved artery here is the middle meningeal artery. And as we learned earlier, that the most common location was the temporal bone, and the MMA runs along the temporal bone. So the most common artery to get injured is middle meningeal artery. As compared on FDH, the most common location is along the cerebral convexities. Here in the image you can see that there is this acute bleed along the cerebral convexities, and the bleed in FDH is a venous bleed due to injury of bridging veins. So a very important point differentiating between the two is crossing of sutures and midline. Now I haven't yet spoken about the shape because shape is not a definite criteria to differentiate between the two. You'll get sometimes confused what kind of bleed it is when the bleed is small. So shape is not really a criteria to differentiate between the two. Remember, EDH being outside the dura cannot cross the sutures because at the site of sutures, the dura is stuck to the periosteum. So the EDH will not cross the sutures. However, FTH is below the level of dura and hence it can easily cross the sutures, right? However, with respect to crossing midline, the sequence is reversed. So EDH, as you can see in the image here, EDH is lying outside the dura, and hence the dural venous sinuses lie below it. Hence, EDH can cross the midline and the dural venous sinuses. However, FDH is below the level of dura, so it cannot cross the dural venous sinuses and hence the midline. So remember this point, that suture crossing is a feature of FDH, however midline crossing is a feature of EDH. So just a brief revision. As we said that EDH occurs due to rupture of meningeal arteries. It cannot cross the suture, however it can cross the dural venous sinuses and the midline. And an important point to see in EDH is sometimes you get an image like this in which there will be some hypodense areas present within this hyperacute bleed, which is biconcave in shape and if it is not crossing the sutures. Okay, so what are these hypodense areas? So in very active ongoing bleed, the hyperacute blood is not hyperdense. Okay, so it will appear as hypodense areas within this bleed. This is also known as a swirl sign, and it is a sign of it being an active bleed, and it is a poor prognostic sign, and in such cases usually decompressive surgery is done to relieve the intracranial pressure. Now this image on the right, here we see that there is a hypodense bleed along the cerebral convexity, which is pushing the brain towards the left. So there is this midline shift towards the left. Now, what is it? So it is crossing the sutures. So it is an FTH. However, it is not hyperdense. It is not bright. So as we all know that chronic bleed is hypodense to the brain parenchyma, right? So chronic bleed will be hypodense to the brain parenchyma, and so in this case, it is a chronic FTH causing midline shift. In FTH, when do you do a decompressive surgery? If there is a midline shift of 5 mm or more, the patient needs to be taken for decompression surgery. Now coming on to the subarachnoid hemorrhage, it is usually in trauma setting. The SCH usually occurs due to rupture of cortical branches, and in trauma setting, SCH is usually sulcal. So that is, it is along the cerebral convexities in the sulci. Whereas in non-trauma setting, the SCH is along the basal cisterns because of the rupture of berry aneurysms, which are along the circle of Willis. So the most common cause of SCH overall is trauma. However, in non-trauma setting, the most common cause of SCH is aneurysmal rupture. Remember this. So just a previous year question which was asked with respect to SCH was a middle-aged female with sudden onset of headache and neck rigidity. There was no history of trauma and CT scan images shown below. What would be the probable diagnosis? Now with headache and neck rigidity, a lot of people would answer meningitis. However, the given CT is of a non-contrast CT, right? So how would you say that it is a non-contrast CT? Here we see that the dural venous sinuses are not getting enhanced. So here we do not see that the superior sagittal sinus is enhanced, as well as the cortical branches are not getting enhanced. So it is a non-contrast CT, and there is this bleed along the sulci. So it is a case of SCH. Now, can SCH cause neck rigidity? Yes. SCH can cause meningeal irritation, and that can cause neck rigidity. So here the answer to the question is SCH. Now, intraventricular hemorrhage. What is intraventricular hemorrhage? It occurs due to shearing of intraependymal blood vessels, and here you can see that there is hyperdense content seen within the lateral ventricles, which is causing some hydrocephalus. Now coming on to intraaxial bleeds, the two most important intraaxial bleeds are cerebral contusions and DAI. So cerebral contusions are mostly hyperdense intraparenchymal areas secondary to trauma, and they occur at the site of head injury. Now sometimes what happens that suppose the trauma is at this site, there be a contusion or a head injury, brain injury at this site. However, on the contralateral side as well, you'll see some sign of brain injury, maybe an FTH, EDH, or some even brain contusions. So these are known as coup and counter coup injuries. That is, at the site of injury, you'll have a coup injury, and opposite to it, you'll have a counter coup injury. Right. So the most common location of a cerebral contusions. Firstly, you have to remember that these are cortical base. So contusions are cortical base, and their most common location is the frontal lobe and temporal lobes, right? And this is in contrast to diffuse axonal injuries. Here the injury is subcortical, that is, it occurs at the gray matter white matter junction, and the most common location for a diffuse axonal injury is the frontal lobe and the splenium. Correct. Now, when to suspect a DAI? So, as we saw in the MCQ earlier, the DAI you have to suspect when there is a low GCS of a patient who has undergone a high energy trauma and the NCCT is still normal. Usually, what you will see in a high energy trauma with low GCS, the patient will have a lot of cerebral contusion, will have an EDH or FTH. However, if such low GCS patient has a normal NCCT scan, you expect a diffuse axonal injury. Now, what is the investigation of choice when DAI is concerned? The investigation of choice is an MRI. The investigation of choice is an MRI, and among MRI, the sequence of choice is a susceptibility weighted imaging, also known as which is a gradient recall echo based sequence, right? What will the findings of NCCT? The findings on the NCCT can be either normal or they can be punctate hemorrhages occurring at the gray white matter junction. So here in the image on the left hand side, you can see that there are these punctate hemorrhages which are seen in the frontal lobe at the gray white matter junction. Here also you can see, and these are very fine small cell hemorrhages which are seen on non-contrast CT. However, if you do a normal MRI, so this is a T2 weighted image. Now why do I say it's a T2 weighted image? Because the white matter is gray and the gray matter is white. So I'll discuss the imaging appearance of MRI of each sequence in the basics of MRI and the basics of radiology. However, at this point, it's just suffice to note that this is an axial T2 weighted image, and here you do not see any obvious abnormality. However, if you do a susceptibility weighted imaging, you'll see that these punctate micro hemorrhages are more prominent here. So what do you see? What is it called? It is known as blooming. It is known as blooming. So what does acute blood do? Acute blood has hemosiderin within it, iron, and hemosiderin has iron within it. So what does iron do? Iron causes a field inhomogeneity. Field inhomogeneity within the magnetic field, and that causes blooming. And so on FWI, acute bleed and hemorrhages in general appear as blooming foci. So and hence MRI is the investigation of choice for diffuse axonal injuries. So just a previous year question, a young male meets a road traffic accident and is brought to the emergency in an unconscious state. He is intubated with low GCS and the NCCT head and C-spine was normal. What could be the likely cause? So few keywords here. It was a road traffic accident. Patient has a low GCS and the NCCT head was normal. So if we combine all these three, we know that the answer is DAI. Now few spotters and one-liners, straightforward questions that are sometimes asked. So what is this image showing? It is showing air within the cranium. Now this is not normal air. This all black here is the air. However, this air is pushing the brain parenchyma medially and teething the brain parenchyma towards the skull. So the brain parenchyma is under tension, and hence this is not a normal pneumocephalus but a tension pneumocephalus. Now what is this sign known as? This sign is known as Mount Fiji sign, right? So another one-liner spotter which is sometimes asked in the exam is a caratico-cavernous fistula or a CCF. So the patient will have a typical clinical presentation of a history of head trauma, and following few months the patient develops chemosis of one eye and has a pulsatile proptosis with conjunctival ingestion or conjunctival redness. So what will be the findings on CCF? Remember that the initial investigation of choice will be a CT angiography, and what will you find on CT angiography? That the cavernous sinus will be bulky, and the cavernous sinus, as we know, drains the superior ophthalmic vein. So the superior ophthalmic vein of the ipsilateral eye, which has pulsatile proptosis, will also be enlarged. So an enlarged superior ophthalmic vein and enlarged cavernous sinus suggest a CCF. Now what is the gold standard? The gold standard is a DSA or a digital subtraction angiography. What will you find on DSA? You'll find that in the arterial run itself, that when you inject the contrast, in the arterial phase itself, the cavernous sinus and the superior ophthalmic vein is opacifying. So that means that there is a communication between the arterial system and the venous system at the level of cavernous sinus, and hence it is a gold standard of a caratico-cavernous fistula diagnosis. Now coming on to skull fractures. Skull fractures are divided into linear and depressed skull fractures, and amongst linear skull fractures you have a simple linear fraction in which there is a cortical breach and the fracture fragments are not displaced or depressed. However, in a depressed skull fracture, the fracture fragments are depressed or displaced from their location, and they can injure the underlying brain parenchyma as seen here. Another type of skull fracture which is especially seen in children is a Pond's fracture or a ping pong type of fracture. Now children have a special skull in the form of that their skull is little malleable or pliable. So even if there is a trauma to the skull, there is no bone fracture. However, the bone bends inwards like a ping pong ball when it's hit too hard, right? So that is known as a ping pong fracture in children or a pond fracture. Another skull fracture that you'll encounter is a temporal bone fracture. Now, this is covered in ENT as well, but I'll cover this along with skull fractures so I have to complete the skull fractures. What is the initial investigation or the investigation of choice for temporal bone fractures? It is a temporal bone HRCT. And remember, for imaging temporal bone in general, the investigation of choice is an HRCT temporal bone. Now, there are two types of temporal bone fractures, namely longitudinal and transverse fracture. Now, this is sometimes very confusing to remember ki which one is which. So, just remember by saying that longitudinal fractures are along the petrous temporal bone, along the petrous bone, right? So this we know that this is the petrous part of temporal bone, and longitudinal fractures are along this petrous bone. However, as in contrast, transverse fractures form a T with the petrous bone, hence they are called transverse fracture. Now, as logic would say, when there is a transverse fracture, there is possibility of injury to the otic capsule, that is the membranous labyrinth, as well as the facial nerve and the vestibular nerve, which runs along the internal acoustic meatus. So, transverse fracture are associated with otic capsule injury and have a sensory neural hearing loss, and an associated facial nerve paralysis can also occur. However, a longitudinal fracture like this is more likely to injure the tympanic membrane and the ossicular chain, and hence longitudinal fractures are associated with conductive type of hearing loss and TM rupture. Now, what is a growing skull fracture? So, this was a question which was asked in 2017 in AIMS PG, and it was a new question back then. So, what is a growing skull fracture? So, to understand this, there are a few keywords associated with this entity, namely a delayed complication, it is a child, and there is a associated dural tear. So, what will happen is that in a child, 3 months to 1 year after the initial trauma, they'll present with the increasing swelling over the scalp. And what actually has happened inside was that there was a dural tear, and from that tear, the CSF keeps on leaking slowly and slowly and slowly. So imagine that there is a dural tear, the CSF is leaking and is contained only by the arachnoid pia, and slowly the cyst keeps on increasing, and as the cyst is increasing, the fracture, which hasn't healed yet by the way, keeps on increasing and keeps on increasing. So hence it's called a growing skull fracture. It is a misnomer because the underlying pathology is a dural tear and the skull fracture is not growing per se. But this is what the underlying pathophysiology of a growing skull fracture is. Right? So this was part of today's lecture, and thank you.